Most of the time when folks talk about acquired brain injury, they're talking about something that wasn't related to trauma, but really acquired brain injury is an umbrella term for all brain injuries. And it doesn't matter what the cause is, there is something that happens that affects the physical integrity of the brain and or how it functions. And it results in a change into how the brain needs and uses energy and how its neuronal pathways operate. And we're going to talk about this in a little bit more detail later on. But under the umbrella term of acquired brain injury, there are two types of injuries. One, obviously, is traumatic brain injury. That is defined as an alteration in brain function or other evidence of brain pathology. It's caused by an external force and can be defined as closed or non-penetrating, or open, penetrating. An open head injury could also mean a significant fracture of the skull. Non-traumatic brain injury is usually caused by internal factors. There is a definition of brain injury that appears in the Code of Virginia, and I realize I have to update this slide. I'll do that after the presentation. This definition appears in the section of the code that pertains to residential placements for persons with brain injuries. It's a licensing code. So it says it's any injury to the brain that occurs after birth. We took out that before 65. That's acquired through traumatic or non-traumatic insults. And so when we talk about non-traumatic, we're talking about things like a loss of oxygen to the brain or decreased oxygen to the brain. We're talking about something like an aneurysm or a stroke, which has to do with the blood vessels in the brain. We're talking about things like toxic exposure or an opioid heroin overdose. We're talking about encephalopathy and infections and surgical interventions. Generally, when we refer to brain injury in the brain injury community, we're talking about those injuries that are not hereditary or congenital or degenerative, and those injuries that aren't induced by birth trauma. There is some period of normal brain development outside the womb, and then something happens. There are just shy of 3 million people annually who sustain a traumatic brain injury. And remember, this doesn't include all the folks that sustain a non-traumatic brain injury. Of this 3 million, about 2.5 will only visit the emergency department. That's a significant figure. I hope you connect some dots on later. There are just shy of about 300,000 hospitalizations, and about 50,000 people die each year. Brain injury is the leading cause of injury-related death, and it's responsible for more years of injury-related disability than any other cause worldwide. We know that kids and older adults are disproportionately affected by brain injury, and that about 75% of all traumatic brain injuries are classified as mild. I think this is a really interesting slide. This came from the Coma Institute for Cognitive Disabilities, and this ought to look familiar to you guys. It's the prevalence of cognitive disability in the United States. So you'll notice on this slide that brain injury is second only to severe persistent mental illness. There are more people with cognitive disabilities from brain injury in the United States than there are developmental and intellectual disabilities and Alzheimer's and stroke. This is according to the Coma Institute for Cognitive Disabilities. It's the second most prevalent disability in the United States, following depression. An estimated 5% of the population, or more, about 13.5 million Americans, are living with a brain injury. We know that overall the rates of brain injury have gone up gradually, but the rates of death have dropped during the same time frame. This is a picture of the Duggards because I figured they covered every group of people we were going to talk about in terms of age. The age groups who are most at risk are children 0 to 4, and their primary causes relate to falls and abuse. Adolescents 15 to 19 are at risk from motor vehicle accidents. Young adults 20 to 24, firearms and motor vehicle accidents. And adults 65 and older sustain their brain injuries as a result of falls. TBI is a really, really expensive problem. A severe brain injury costs a mad $3 million over the lifetime, a moderate injury about $1 million. The costs for care of people with a new brain injury is $6.5 billion per year, and the ongoing care is $13.5 billion. And this totals over $50 billion when you add in the indirect costs. We know that while the costs of care are going up, insurance companies are decreasing length of stays. People are being discharged sicker and quicker. They are reducing the amount of benefits paid, which therefore reduces the amount of rehabilitation someone will receive, and it produces a crisis in payment for long-term catastrophic injuries like TBI. Rates of, when I first started practicing as an occupational therapist, we'd have patients in rehab. So they'd already been through acute care, and they might have been in acute care 4 to 6 weeks. Then they'd come to rehab and they'd stay 2 or 3 months. And now people are lucky to get 2 weeks of rehab paid for. And only 1 in 20 people who sustain a severe brain injury have adequate insurance funding to access comprehensive rehabilitation services. When you look at the numbers in the state of Virginia, what we know is that there are about 8.5 million Virginians. The prevalence of TBI in the state of Virginia is about 863. 1 in 10 Virginians are estimated 863,000. 1 in 10 Virginians are estimated to have had a brain injury at some point in their life. We know that there are about 250,000 persons in the state of Virginia who've had a stroke. And so those 2 causes alone, just traumatic brain injury and stroke, is 1.1 million people. If we were to add in the other causes of brain injury, that number would go up. Estimates state that there are about 2% of the general population who are disabled as a result of brain injury, and that equals about 172,000. We know that about 130,000 folks in Virginia are disabled, but not in an institution because of their stroke. So we've got about 302,000 Virginians living in the community as a result of brain injury or stroke. Every year, the Department of Health estimates about 28,000 individuals sustain an injury. The numbers that you see on the far right of the screen are the percentages of those injuries that fall into the severe, moderate, mild, and unknown causes. So this 23,000 number, I can guarantee you that almost all of you have someone with a brain injury who had a mild brain injury on your caseload. I'm going to get into some of the weedy parts of brain injury, but what we know about how the brain works is going to apply to a lot of what I'm talking about today is going to apply to everybody that's on your caseload, whether or not somebody has a brain injury. Our goals with our clients are improved executive functioning and adaptive interpersonal skills, just like the people you serve. So there are things that you are going to learn that pertain or could help serve individuals with autism or serious mental illness or severe emotional disturbances. So keep all those things in mind and feel free to ask questions about that as we go. We talked a little bit earlier about traumatic and non-traumatic injuries, and I want to get into a little bit more detail about that. So the traumatic or external causes of injuries you see on the left-hand side of your screen. Falls and car accidents we've talked about quite a bit. Certainly sports accidents have taken our attention. Another cause of traumatic injury is assault, whether someone is shaken or beaten, gunshot and stabbing wounds, and military actions. The non-traumatic causes are related to stroke or aneurysm. What happens in a stroke or an aneurysm, part of a blood vessel wall gives way in the brain. That's the easiest way to describe it. With an aneurysm, there is something congenital in the brain that finally gives way. With a stroke, it can happen one of two ways. It can be because of a clot that cuts off blood supply to a part of the brain, or it can be due to a vessel just sort of bursting open under pressure. If you go to a hospital these days and you are thinking that you're going to have a stroke, one of the things that's going to happen is they're going to determine very quickly if this is stroke due to a bleed or due to a clot. Because if it's a stroke due to a clot, they have clot busting drugs that can be administered in the first hour, which will significantly reduce any effect of the stroke on physical and cognitive function. Seizure disorders can be a cause of traumatic brain injury because sometimes when people have a seizure, they stop breathing. Talked a little bit about toxic exposure and opioids, a little bit about brain tumors, and there can be metabolic causes of non-traumatic brain injury. I had a patient one time who was driving his car when he experienced a diabetic low and crashed the car and sustained his injury that way. So I want to talk for just a minute about a little bit more distinction between primary and secondary injury and internal and external injury. So when you have an internal injury, it can be because of a stroke or a brain tumor, which may affect a certain portion of the brain. You could have a brain injury, as a result of something like a tumor or oxygen deprivation. Many individuals, after they've had a cardiac incident, have memory problems because there's a portion of the brain that's really sensitive to loss of oxygen, and it's a really important feature for memory. People who have been strangled in a domestic violence assault will have oxygen deprivation as well. When we talk about the external causes of injury, usually there is a biomechanical force associated with that external injury. You can have an acceleration or deceleration type of injury, which is also known as coup or contra coup. You know, the brain sits inside the skull and it's sort of held into place by fluid and by little sort of crags and pockets inside the skull. But when your head moves forward rapidly, as might happen in a car accident, one of the things that's going to happen is it's going to snap back. It's just the biomechanical force. It's sort of like a basketball hitting the pavement. But when that happens, that can cause significant damage throughout the brain. We'll talk about that in a little bit more detail later. Another one of the external causes of injury could be because of rotation of the brain on the brain stem. The brain, which is about 3 pounds, sits on top of the brain stem, which is about the size of your thumb. So it's sort of top heavy. And if you've ever played with a bobblehead, you know it doesn't move in a straight line back and forth. It bobbles around. And so we think that when someone sustains a traumatic brain injury, there is some rotation of the brain on the brain stem, and that's what causes a loss of consciousness. Cavitation is an injury that occurs as a result of exposure to a pressure wave, like what happens in an improvised explosive device. The brain is largely made up of fluid, and when the pressure wave comes at someone, it creates a phenomenon that looks an awful lot like what happens in a pot as it begins to boil. If you've looked in a pot and you've seen those little bubbles at the bottom and how they start to just sort of go, well, that's sort of what happens to the brain when it's exposed to a pressure wave. And all of these things can lead to diffuse axonal injury. There are neural pathways in the brain, and you can think about them as highways. And so the highways get us from one point to another, and that's true in our brain. But when there is an accident on the highway, it messes things up. And when there's an accident on the neural pathway, it messes things up. These neural pathways can be damaged in all of these external causes of injury. And that sort of creates potholes, if you want to think about it that way, or detours in the brain. We have to find ways around the damaged portions of the brain to create new skills. But this diffuse axonal injury occurs throughout the brain, and so the entire brain is affected. When there is an external injury, there's also the likelihood of some sort of secondary brain injury that occurs. We know that blood flow is disrupted. We know that the brain can swell. If you've ever had a really nasty bruise, you know that it sort of pooches out, but there's no place for the brain to pooch out when it gets bruised. It sort of internally collapses on itself and it begins to damage the structures that it starts to push on. We know that chemical messengers are impaired in terms of how they get from one cell to another. And we know that how the brain uses energy is disrupted. The brain needs a lot of oxygen and it needs a lot of glucose. The brain is an energy hog. And when brain injury happens, its ability to use those energy sources is impaired. And individuals can sustain cell death as a result of their external injury. It's really important to recognize that brain injury is not an event. It causes chronic physical, cognitive, and mental health issues, and it is not a treat with meds and it's all going to get better situation. You can't cast the brain like you cast an arm. Brain injury is a lifelong chronic illness. I want to show you this video, which will demonstrate this axon shearing during injury. You'll notice that the brain moves forward and backward as the skull moves forward and backward. And then this little cross section shows you the difference between white matter of the brain and gray matter of the brain, and how those neural pathways develop potholes at the junction of those two parts of the brain. And that's critical in determining how we act and how we get things done. We do rate injuries in terms of their severity. Mild brain injuries usually have some sort of presentation, but doesn't have to involve a loss of consciousness. Somebody could just be woozy, for example. Individuals who sustain mild brain injuries may vomit, they may become dizzy, they may have some amnesia for the event, and they may be very tired. Most individuals who sustain a mild brain injury completely recover from that injury, if it's their first injury. Someone who has a moderate brain injury is going to have a period of unconsciousness for some period of time, up to 24 hours. There will be neurological signs of trauma, and they may have some findings on an EEG or a CT scan. You'll notice that I don't say that about mild TBI. Most of the time, a CT scan, when someone has had a mild brain injury, will be negative, which is a huge disservice to the individuals that we treat. When they hear negative, when the insurance company sees negative, they don't understand that a brain injury can cause lifelong issues. They think something else is wrong. When someone has a severe injury, we know that it's marked by a period of unconsciousness of more than 24 hours. These are determined by something called the Glasgow Coma scale. And so you'll see over there, a mild injury is 13 to 15, moderate is a score, overall score of 8 to 12, and severe is 3 to 7. If you show up at the ER and you're breathing, you get a score of 3. If you are ever doing a chart review and you see something abbreviated GCS, that stands for Glasgow Coma scale, and that's going to be an important piece of information to determine the effectiveness of your interventions. Like I said, most times when somebody has a mild injury, the CT, maybe even the MRI is going to look normal, and most people are going to recover. But if they have had previous injuries, that likelihood does diminish. And again, these folks aren't necessarily likely to have therapy unless there's some sort of symptom that persists and somebody connects it to the brain injury. Folks who have a moderate injury will likely have some therapy. They may actually receive inpatient rehab. And although few of these folks die, about half of them do not experience a good recovery. And for individuals who've had a severe injury, there is a prolonged loss of consciousness. There may or may not be any physical disability at all, which is sometimes problematic for folks with brain injuries. And these are individuals who are usually transferred to a rehabilitation unit once they're medically stable. So this is a slide that looks a little bit at some of these psychological features and mild TBI. And you can see that in terms of headaches, if you have a concussion or stress or anxiety or PTSD or depression, that's a common feature. Concussion is common with all of these till you get down to worry, and then dizziness or loss of balance, impaired hearing, and blurred vision. I love this quote because basically what this doctor is saying is there is not a heart doctor in the world who would say, don't worry about your diet and feel free to keep smoking and you don't have to exercise until you have the big heart attack. But we do that to people with mild brain injuries all the time. We tell them they're okay when they're not. And when people who are uninformed about brain injury, particularly doctors, give them a diagnosis that's not quite right, it takes them a long time to find the right doctor and the right providers to get better. There are a number of things that can determine the effect of a brain injury, and you'll see down at the bottom of the slide, I've said that if you had one injury, you're 3 times more likely to have another injury. And if you've had 2 injuries, you are 8 times more likely to have a third. So when I say that most people with mild brain injuries will experience a good recovery if it's their first injury, this is the sort of thing I'm talking about. We know that the severity of the injury determines its effects, as does the age of the injury. We know that a history of alcohol or other substance use disorders can affect brain injury, domestic violence, participation in sports, service in the military, all of those things determine the effect of brain injury. But I want to take just a minute and talk about kids, because while the symptoms of brain injury in kids look a lot like the symptoms that our adults may experience, the functional impact can be much harder on kids because that brain is still continuing to develop. And we know that there are common problems after brain injury that include things like information processing and judgment and reasoning. And when you're a kid, it's going to be years before you have to use that skill. That's why everybody thinks kids have these miraculous recoveries from brain injuries. But the truth is, most brain maturation occurs from birth to 5. And an injury in that time frame is the most devastating time for injury to occur. And a lot of times developmental stages and challenges after brain injury, are overlooked because the kids look okay. And this is a video. I want to see if I can show you.
We can't hear the video.
And when you shared, did you share your sound as well? Because we cannot hear the video.
I don't think I did, and I'm not sure I know how to do that. Let's see.
If you stop sharing, and then when you go to share again, at the bottom of the screen, there should be a checkbox that says share sound as well.
A checkbox, it says, I don't see that, Annetta. I'm looking at.
So it should say share sound. It should be in the bottom left.
Click the share screen first, click share screen, and then when you have an option to decide which page you want to show at the bottom left, you should be able to click optimize for sound, for share sound.
Okay, now let's try it. You hear it now?
Yes, we can hear.
Yeah, it's a common misconception that having a brain injury as a younger child is a good thing. And that's based on the idea of plasticity, that the brain is malleable and that the early brain has more potential for change and recovery. And that's called the early plasticity model. But the converse of that is actually true, because there's research to show that the brain is actually more vulnerable at that time because it hasn't laid down all the foundation skills and all the foundations that it needs to, so that the child development can then go on growing on top of the things that is laid down early on. Having an injury as a child, there's a couple of things that make it different from an adult. So one is that your skull hasn't quite finished knitting together to be a solid structure. So if you have an injury to your head and your brain as a young child, the brain will move inside the skull a little bit more, and so there can be more parts of the brain that can get damaged, rather than in an adult where the skull is a solid structure that holds the brain in place a little bit more. That's one thing. Another thing is that there's parts of the brain that develop at different times. So say the frontal part of the brain, the frontal lobes, and particularly the prefrontal cortex, that takes a long time to develop, and it's really into your 20s till that's really finished maturing. So if there's jobs that come online as a teenager, all that organizing and multitasking and reflection, then you won't know that they've been affected until later on, when those areas of the brain need to come online.
So this is just sort of an overview of some of what she was saying. We know that kids who sustain a brain injury at a young age don't have the same number of life experiences to draw on for cognitive and behavioral skills. And up to 50% of kids who are injured as a child, or kids who sustain an injury, are at risk for behavioral problems. And sometimes they emerge after the injury, and sometimes it can be several years. But often they persist and can worsen over time. So you think about anybody that you've ever done an interview with, you're taking in new patients who said, you know, things just got worse as they got older. And, you know, maybe it's because somebody doesn't remember a brain injury happened. When we control for other variables among kids with service needs, those with mild injuries were far more likely to have unmet needs than those with moderate to severe, because they look fine and they're kids. And what we ask of young kids isn't the same as we ask of older individuals. And so when these kids begin to grow up, they grow up under the shadow of the brain injury, but nobody's recognized the brain injury. And so many of their needs aren't met. They just assume that the child is a poor learner. They just assume that the child is hyperactive. They just assume that the child is behaviorally or emotionally disturbed. Traumatic brain injury during early childhood is associated with a particularly high risk of social behavior impairments, social cognition, social interactions, and all of those things have profound consequences for someone's quality of life. So after a brain injury, individuals will have problems with a lot of these body systems, their ability to use the restroom, the musculoskeletal framework of the human body, how their gut works. I don't know if any of you have been reading all of this stuff now on the gut being the second brain of the body, how their reproductive functions work, and are they sexual still? Cardiovascular issues, they'll have metabolic and endocrine issues. There could be skin and other infection sorts of medical complications. There could be problems with sleep and other neurological systems. I work with a guy, I know a guy who runs a program out in California. And one of the things that he said one time that really got my attention, he said that they had admitted into their program one of a set of identical twins. And identical twins are not fraternal. These guys are identical. So the twin that he had admitted into his program had been hit by a car when he was riding his bike at 6. And the boys had developed normally and in tandem until that point. But after that point, the growth of the individual who had had the brain injury stalled. And at the time of this guy's admission into the hospital, into this program, he was something like 24. He was something like 5'7", and his identical twin was 6'3". And so that's a really visible representation of some of the damage that can happen to the body after a brain injury, particularly the metabolic and endocrine systems. Brain injury begins a disease process. It is disease causative and disease accelerative. It impacts a lot of different organs, as we've talked, and as you see on this slide. If you have a brain injury, you are 37 times more likely to die from a seizure, and 7 times more likely to die from some sort of respiratory complication. And we know that brain injury is a risk factor for epilepsy and sleep problems and psychiatric disease and Alzheimer's disease and chronic traumatic encephalopathy, or football players' disease. We also know that brain injury shortens the lifespan. For individuals who have a moderate to severe injury, that reduction is about 7 years. And even if you have a mild injury, there is a small but significant reduction in long-term survival. So when somebody has a brain injury, they're faced with an awful lot of challenges. They may have cognitive and physical changes that you see. Their attention may suffer. They may have memory problems. They may not be able to speak as well or find the right word. They can't exhibit, or they struggle to exhibit, good executive function. And we're going to talk about that in some detail later. There may be, but may not be, actual intellectual loss. People with brain injuries can sometimes get stuck on an idea or a thought and find it very difficult to shift their cognitive set. They might have sleep problems, probably do have sleep problems, headaches, visual problems, dizziness, vertigo, seizures. That's just the top of the list. But then you look on this right side of the screen and you see all of those emotional and behavioral changes that individuals with brain injuries might have. And I know you know this list. And I'm wondering how many of you are thinking about folks on your caseload that you're thinking about maybe a little bit differently now. People with brain injuries can be irritable. They may have issues with rage. Depression and anxiety are very common after brain injury. Individuals can have psychomotor agitation, which falls over into perhaps even aggression. They can sometimes be disinhibited. They may have something that looks like apathy because the part of their brain that tells them to get up and go has been damaged. They may be impulsive in their decision-making, have difficulty understanding the effect that their behavior has on others, which means that they can be self-centered and not terribly self-aware. It's 9:46 and we were going to take a break at 9:45. I'm going to give everybody 15 minutes. I appreciate you sort of sticking with me. We know that these virtual presentations can be draining. So get up, march around your office, go get something cold to drink, take a bio break, and let's meet back here at 10 o'clock. We're going to be going over some anatomy and some cognitive functioning in the next section. You know, coma is a fairly defined period of time. It's a state of unconsciousness that can sometimes last years, but generally doesn't last that long. Most people will eventually move into something that could be called vegetative state, and some folks are calling minimally responsive. It's a very low level of consciousness. It does follow coma. And these are individuals who appear awake, but can only perform some involuntary responses, and they don't necessarily follow commands. Someone in a minimally conscious state has an altered consciousness, and this person can display some acknowledgement of self or environment. They may be able to turn their head to locate sound, or they may be able to blink yes or no. They may smile when they hear music. So they're processing something external to them on some level. But someone in a vegetative state is likely having more reflexive responses. Years ago, there was a case involving someone who had had an anoxic injury, Terry Lynn Shivo, and her husband, after many years of Terry living in basically a vegetative state, wanted to withdraw life-sustaining measures, and her parents didn't. And they were saying that they could get her to smile and to track. And probably what was happening is she was having some rather reflexive responses. None of those responses could be reproduced with any consistency by anyone else. And so that's one of those things that we look for when we're talking about disorders of consciousness. Seizures can be very common after brain injury. We know that seizures can be a cause of brain injury. It's a production of excessive electrical forces in the brain, and there are several different types of seizures that persons with brain injuries can have. There's the grand mal, which I think we've all heard referred to. It's also called a tonic-clonic seizure, but generally it's prescribed or described these days as a generalized seizure. Partial seizures can involve one side of the body or one part of the brain.
This is a basic introduction on how to recognize and respond to a seizure. For people who have had a brain injury, there is an increased risk of seizures. Our brains send messages through a complicated system of nerves. These messages allow us to think, feel, and move. During a seizure, the messages are briefly disrupted in the brain, causing an electrical overload in part or all of the brain. Seizures are most common during the first year after a brain injury. When having a seizure, a person is at risk for getting other injuries, especially if they fall. Injuries can include broken bones, injuries from biting their tongue, further brain injury from hitting their head. In extreme cases, it can even lead to death. Not all seizures are alike. Partial seizures occur in one part of the brain and may affect only part of the body. Generalized seizures affect all of the brain and usually all of the body. It's not uncommon for a partial seizure to develop into a generalized seizure. A person having a generalized seizure may show symptoms that include muscle contractions, stiff, jerking muscle movements, vomiting or loss of control over bladder and bowels, a blank stare during the seizure, loss of consciousness. If you are with someone who is having a seizure, there are several things you should do to help them. If you are in the hospital, call the staff for help immediately. If you are at home or out in the community, protect the person having the seizure. You can do this by gently lowering them to the floor, turning them on their side to prevent choking, and calling 911. Make sure the person is safe. Clear the area and make sure to remove all sharp or hard objects. Next, check to make sure that they are breathing. Loosen clothing and anything else that might make it hard for them to breathe. Do not place anything in the person's mouth, including silverware, sticks, or your fingers. Do not hold the person's tongue. It is important not to restrain or leave this person alone. Creating a calm and quiet environment is helpful for everyone. Most seizures will end in less than 5 minutes, even though it may seem longer. Following a seizure, a person may need to rest or sleep for a while. They may be confused. They may have a headache. They may feel weak in the arms and legs. They may have a hard time speaking, and previous problems from their brain injury may return for a short time. Things should go back to the way they were before the seizure happened. Do not give them anything to eat or drink until they are fully awake and able to swallow safely. Seizures usually can be effectively managed by you and your healthcare provider. Learning to recognize and respond to a seizure when it does happen is important for everyone. Discuss your particular risks with your physician.
Another problem that individuals can have after brain injury are headaches. These can be acute, or they can turn into chronic headaches. They can be because of some musculoskeletal damage, or possibly something more neurologically related. Headaches are frequently undertreated in this population, and anybody that's ever had a really bad headache knows that it just sort of makes you stupid and grumpy. And so, you know, that's not a bad question to ask individuals with brain injuries when their behavior seems sort of out of the norm. Sleep disturbances are a problem in the population as a whole. We all do a very bad job of taking care of our sleep needs. But when people with brain injuries aren't sleeping, it's sort of, you know, insomnia on steroids, if you want to think about it that way. We know that poor sleep affects your mood and your behavior. And we also know that it can lower seizure thresholds and increase depression and irritability. After brain injury, sleep patterns can be disrupted because of changes in how a person moves in bed or can't move in bed. It can be a result of some of the neuroendocrine stuff we were talking about earlier. It could be any combination of things, but they're going to increase some of the changes that we see as a result of brain injury, the challenges of those things like depression and irritability. And when people sleep, they have improved cognitive function, attention, and reaction time. I'd like to see everybody with a brain injury go through a sleep study myself. We also know that individuals with brain injuries have primary and secondary fatigue. So primary fatigue in persons with brain injuries is very often related to damage that the brain injury has caused. You know, there's a part of the brain called the reticular activating system. It's what gets you up in the morning. It's what tells you to be awake when you're sitting up. And so the reticular activating system can be damaged when there's a brain injury. And so structural problems can actually create primary fatigue. And when you add on some of these secondary causes of fatigue, you begin to understand the challenge that some of these folks are up against. We've talked about sleep disturbances, and stress, pain, anxiety, and depression are all factors in making somebody feel more fatigued than they are. Pain is exhausting. And so individuals who have, you know, perhaps altered gait patterns or who may have to sit in a wheelchair all day are going to have some of those things that just make life tougher. You know, I like to tell a joke about docs, and, you know, one of those things says, you know, 50% of all doctors graduated in the bottom half of their class. But I really like this one because this is the first day of brain surgeon school, and the professor is saying, good morning, students. On each of your tables, you should find a Mr. Potato Head. And, you know, sometimes that's how we feel about it. But the brain really does need to be very, very carefully handled. And you can see these are slides of anatomical specimens of real brains. The brain weighs about 3 pounds in an adult, and it has the consistency of congealed oatmeal. And you can put your finger through it with no effort at all. And how is it that something like this created the interstate system and put a man on the moon and painted the Mona Lisa? It's really quite incredible when you think about it. How does this thing make our lives possible? So, you know, the skull is a rounded layer of bone that really pretty much protects the brain from penetrating injuries most of the time. But when you look inside the skull, it's very rough. It doesn't look anything like the outside of the skull. It has a lot of bony ridges, and those ridges result in injury to the brain when it starts sloshing around in the skull. I told you earlier today that the brain is bathed in fluid. It sits inside the skull in a little bit of fluid that provides some cushioning. This is called cerebrospinal fluid, and it carries some of the nutrients that the brain needs to function. And it carries those nutrients through ventricles. And the ventricles are the things that you see in sort of yellow-orange here. And you'll see those in some CT scans and MRIs I'm going to show you in a few minutes. But the cerebrospinal fluid goes down the spinal cord and up, and it's just sort of this circular loop that washes and feeds the brain and the spinal cord. It's not designed to be a protective layer. The brainstem is what connects the brain to the spinal cord. It's about the size of your thenar eminence, which is actually your thumb and that pad of flesh that goes along with your thumb. So remember what I was saying earlier about this 3-pound brain sitting on top of this little pad of thumb muscle that you have. So it's going to be top heavy. It's the central point for every piece of information that comes into our brain and goes out from our brain and all of our basic life functions. It controls things like pulse and blood pressure and respiration. It's what tells us when to vomit. and it connects the cerebrum, which is the higher level of the brain, to the cerebellum, which sits lower in the brain. The cerebellum, which you see highlighted here in this slide, coordinates our movements by controlling the direction of speed or force, or how we integrate our movements together to do something like throw a baseball. We know that injury to the cerebellum can create lots of problems with coordination, whether that's fine motor coordination or overall coordination. Sometimes after brain injury, people will develop something called ataxia, where they're very unsteady on their feet and they just sort of can't settle into a position. We know that the injuries can create problems with path or direction of movements and balance, and our sense of where we are in space. The brainstem, the cerebellum, and the limbic system make up sort of the hub of the brain, if you will. And they tend to modulate more basic functions of our brain. The limbic system sits deep inside the brain, and it's really connected to the other parts of the brain because it controls our internal and external responses, because it's the home of the fight or flight syndrome. We've also heard it referred to as the home of the 4 Fs: fight, flight, food, and sex. It's a very primitive portion of the brain, but it has to work with the frontal lobe to match emotions to the situation. So if someone has damage to the frontal lobe, the information from the limbic system that tells them how to emote may not be working. As we move into the brain, into the higher portions of the brain, we begin to talk about the lobes and what they do. The occipital lobe, which you see here in purple, sits at the back of the brain and is responsible for processing all of our visual information. It's how we recognize sizes and colors and shapes and dimensions and light and all of those things. And what I find really interesting is that when your eyes lay on something, it gets to the occipital lobe upside down and backwards, because that's the route, that's the neural pathway that it follows. But when it hits the occipital lobe, it reorients it so we can make sense out of it and send it to other portions of our brain to make more sense out of it. What other portions of our brain might those be? Well, one is the temporal lobe. If you think about the brain sort of looking like a boxer's glove, the temporal lobe would be the thumb. It sits right above the ear and is highly related to memory. It's also related to language, both expressive, or how we speak, and receptive, or how we understand language. And it's associated with hearing. The frontal temporal tip, or the very edges of the brain that you see on the left side of the screen in your head, the frontal temporal tip is frequently injured in individuals with brain injuries. So this is a slide that talks about those language problems that I was talking about. So expression, or our ability to find the right words and produce the sound, as you can see on this slide, is housed in that green part of the brain, very close to the temporal lobe. That's what I was talking about. I was talking about the frontal temporal tip. But when somebody has problems understanding what's being said to them, that damage occurs further back in the brain, at the junction of the frontal, parietal, and temporal lobes. We had a patient one time who I know had some receptive language problems. He would get really agitated for no apparent reason, and all of a sudden he would start screaming, "I can't hear you." But when we dropped the volume of our voice to calm him down, he would respond. And so what was happening was he had some sort of auditory aphasia or reception problem going on, where what he was hearing at various points of time during his day must have sounded to him something like all of the adults in the Peanut cartoon. Wah, 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 wah. And if you don't understand what's happening to you, you might lead yourself to say, I can't hear you, when actually what it is you can't process the language. The parietal lobe sits at the very top of the skull, and it is very connected to sensory sorts of stimulus. It's how and where we interpret touch and temperature and pain. It's how we know our body movements. It's where we know how our body is functioning in space. And it's the part of the brain that tells us the difference between left, right, in front, behind, beside. Then we have the frontal lobe. The lighter green is the frontal lobe. The darker green is sort of the prefrontal cortex, and that strip of white between them is still part of the frontal lobe. The frontal lobe has some responsibility for movement, but it has a lot of responsibility for the executive functions that we need to manage our lives successfully. The functions that make us an executive in our own lives. Things like planning and organizing and judgment and insight and reasoning and impulse control. All of these higher level skills. One of the things that was talked about in that video about kids was, now I've lost my train of thought. Let me see if I can get it back. I'll move on. I like this slide because I think it's really funny. This is the anatomy of a teenager's brain. And so you see that that frontal lobe pretty much is just taken up with the birds and the bees, and the things that they need to be doing, like, exercising good judgment's very small, and their ability to love and disdain their parents is equal yin and yang. But what we know about the brain is that the frontal lobe doesn't wire in until you're about 25, a comment that the woman in the video made earlier. The way that the frontal lobe wires in is by laying down sort of gas on those neural highways. And so the frontal lobe, the prefrontal cortex, is the last part of the brain to get the gas. And that's what leads some of us to make bad decisions when we're kids. It's why when you ask a kid, why did you do that? And they say, I don't know. They really don't. And why teenagers don't think anything bad is ever going to happen to them, because they tend to be fairly egocentric and they don't have the ability to think abstractly. And if you doubt some of this, go back and think about some of the stellar decisions that you made in college that you would never make now. It's because your frontal lobe wasn't completely wired in. Let's talk about the temporal lobe for a second.
Want to learn all the major parts of your brain? I'm going to show you how, and all you need are your hands. Stretch out your hands in front of you. See how the skin on this side of your hands is darker than on the other side? That's just like the outer layer of the brain, called the cortex, or the gray matter. The outside of the brain is darker than the inside because it's lined with neuron cell bodies. Cell bodies are also called soma. Cell bodies keep the neuron healthy and functioning. The muscles inside your hands represent the white matter of your brain. White matter is made up of neuron axons. Axons carry information from one neuron to another. But it's important to remember that two neurons never really touch. If you make a fist with your hands, you can form a shape that's similar to your brain's. This is how human brains are able to squeeze so much gray matter cortex into the small space within your skull. Now take your hands, cross your wrists, and make the back of your hands touch each other. This will help you remember that the left hemisphere of your brain controls the right side of your body, while the right hemisphere of your brain controls the left side of your body. Look closer at your hands. The area where they touch represents the corpus callosum. The corpus callosum is a bundle of nerves that connect the two hemispheres of the brain and help them to communicate with each other. I like to think of it as the Golden Gate Bridge of the brain. Your wrists represent the brainstem. The brainstem sits at the very bottom of your brain. It's the most basic part of your brain and regulates important life functions like breathing, your heart rate, sleeping, eating, and more. This is also where signals from the right side of your body cross over to the left brain, and where signals from the left side of your body cross over to your right brain. Your arms represent the spinal cord. The spinal cord extends down your back. It sends and receives information from the rest of your body. Let's focus on the left hemisphere. Your front fingers represent your frontal lobe. If you remember front fingers frontal lobe, you'll be able to remember that this is the part of your brain responsible for complex and abstract thought. It sits right behind your forehead, and it's the most advanced part of your brain. The frontal lobe helps you to make plans, imagine possible futures, and helps you to control your emotions. It doesn't finish developing until your mid-20s, which is why a lot of kids and teenagers can sometimes do impulsive things. If you extend your index and middle finger, you'll see the part of your hand that represents the parietal lobe. The parietal lobe integrates all the sensory information in your body. Your sense of space, navigation, and touch all get relayed here. But your brain doesn't prioritize each part of your body equally. Take a look at this homunculus map of the primary motor cortex of the brain. You'll notice that the brain prioritizes information from your hands and face. Now look at the back of your hands. You'll notice they look like eyes. This will help you to remember the occipital lobe, the area responsible for your visual information, and how it's located in the back of your brain. Have you ever hit the back of your head and seen stars? It's because you hit your occipital lobe. Take a look at your thumb. See how it can lift away from the rest of your fist, but remain attached to your hand? That's similar to the temporal lobe. The back of the temporal lobe is connected to the parietal and occipital lobes, but the front section can be lifted away from the rest of the brain. The temporal lobe is responsible for understanding sounds and speech. Here's how I remember this. The thumb looks like a temporal lobe, which is important for talking. If we take a closer look at the temporal lobe, we'll find the limbic system. The limbic system is responsible for emotions, learning, and memory. Inside, you'll find the amygdala, an almond-shaped structure which is located just below where your thumbnail is. The amygdala is responsible for basic emotions. Further inside your thumb is the hippocampus. It's sort of where the bone is in this part of your thumb. The hippocampus is responsible for learning and memory. That's it. Now you've got a portable model of the brain that you can take with you and use whenever you need it. Recreate it with your own hands a few times and customize your model by making your own mnemonics. What questions do you have about the brain? Let me know in the comments below.
So I want to talk for a couple of minutes about some brain imaging. I thought I'd show you some pictures. So this is an image of a good brain. You can see the gray matter, which is the darker, and the gray matter, which is lighter, and the white matter, which is the darker. You can see sort of the cushion of fluid, and you can see those holes sort of in the middle of the brain. Those are the ventricles. And what you'll notice is that one side of the brain really does sort of mimic the other. There's a line that goes straight from the front to the back, and everything looks even. But what you can see in these MRIs is a different sort of picture. On the far left, this person had an epidural hematoma with a midline shift because of the fall. Now, what you see is that big dark spot in the middle. There's a bigger side and a smaller side. That's that same ventricle I showed you earlier. You can see that there's been damage on the right side of the skull And there's swelling that is pushing one of those ventricles closed and making the other one swell. In the picture in the middle, you can see the difference between the brain of a normal 27-year-old and the brain of Aaron Hernandez. Aaron Hernandez killed himself in jail as a result of a murder charge after he played football. It's sort of like the trifecta of brain injury. He became involved with the criminal justice system. He exhibited impulsive behavior, and obviously he was depressed. But look at the difference in those two brains, the difference in the amount of white matter and dark matter, and how those structures look completely different. And on the far right of the screen, you see the MRI of someone who has been exposed to a blast. And those dark little pockets at the back of the brain are those exploded little bubbles that I was talking about earlier when I talked about visualizing a pot about to boil. This is another sort of picture of different types of MRIs. We know that we can see on diffuser tensor imaging a much different picture of a brain when someone has a brain injury and they don't. All of these projections are moving throughout the brain and reaching all the way up, and there's just a lot of them. But when you look at the person with brain injury, you see far fewer projections and far less reach. And you can see the difference in the way the different parts of the brain light up in someone with a brain injury and not. Because in a functional MRI, what you expect is that different portions of the brain will light up in different ways when they're performing some sort of a task. And so you see that's not nearly as rich in someone with a brain injury as someone without. I'm going to shift my attention now to talking a little bit about some of the cognitive issues that individuals with brain injuries face. We know that they can have problems with attention, comprehension, perception, memory, and language. Persons with brain injuries may not have the sufficient attention to stick with a task without needing redirection. They may not be able to completely understand the information you're providing to them, whether it's verbal or written, because their ability to process information has been damaged by those potholes on the neural highway. Perception is part of cognition. It determines how we organize and interpret the sensory information that's coming to us. It's how we make impressions of a situation or a conversation. Memory obviously details how we remember things and our ability to recall events and conversations and other details. And then, of course, language plays a role in cognition because it's critical to how we communicate the use of words and how we use gestures to express our thoughts and our feelings and our ideas. Cognitive impairments affect our ability to pay attention to incoming sensory information, to organize, identify, and understand that information, to remember things, to make decisions and solve problems. And all of these cognitive impairments will impact someone's level of independence, their educational or vocational attainments, social interactions, family interactions, and life satisfaction. We know that cognitive impairments can lead to behavioral issues. And I personally think that there are a lot of behavioral issues which are cognitive problems in disguise. People with brain injuries can have difficulty attending to the important things in their environment. They may be completely distracted by the wrong thing. They can have trouble initiating activity or stopping it once they've started. They may be impulsive and disinhibited. They may have trouble understanding the impact their behavior has on someone else and have limited ability to see someone else's perspective. And they may be unable to do what you're asking them to do, so they act out and engage in other maladaptive behaviors. There's a gentleman who works in the learning disabilities field. His name is Richard Lavoie, and one of the things that he said one time is almost any kid would prefer to be viewed as bad rather than dumb. So sometimes when kids act out is to distract you from the issue at hand. Well, the same can happen in an adult after they've had a brain injury. In the field, we talk about there being different domains of cognitive function. And you can see all of those domains here, but we're not going to talk about all of them today. I'm going to highlight a couple of the most important. And because we don't have unlimited processing resources, we need our attention span to work to help us allocate our resources. Attention is one of the most fundamental cognitive skills. It influences all other cognitive skills, and this is a common problem after brain injury. There are different types of attention. You can have selective attention, the capacity to react to certain stimulus when several things are occurring at the same time, when you focus on a specific task and can ignore other distractions. How many of you have been completely absorbed in something on your computer or your phone and somebody is talking to you and you realize that they've asked you a question and you haven't been paying attention? Your selective attention has chosen to attend to something different. You can have alternating attention, which is the ability to switch your focus back and forth between tasks that require different cognitive demands. A great example of that would be talking on the phone and somebody sticks their head in your office and they ask you a question and you answer it and you go right back. You have rapidly switched or alternated your cognitive focus. And then we have divided attention. That's how we process two or more responses or react to two or more different demands simultaneously. You know, we've all read emails while somebody else is talking or surfing the web. And so you're sort of paying attention, but not really. And your selective attention is not focused on the one thing that you need to be focused on. Another domain of cognitive function is memory. It is our ability to pay attention to, encode, store, and retrieve information that we have. In order for us to remember, information has to be encoded, which is the process of converting new information into the framework used by memory. Is this something that we need to store in long-term memory, or is it working memory? We're going to talk about that in just a minute. But what we do know is that encoded information has to be transferred from initial short-term storage to long-term mechanisms. And that's a problem for some folks with brain injuries. Only information that you're paying attention to can be encoded. And only stored information has to be encoded. If it's not, it can't be retrieved. And so it really pertains to our ability to ignore some of the distractors or the difficulty we have in organizing information that impacts what we encode or how we encode it. So let's talk about a couple of different types of memory. Short-term memory allows us to remember that phone number or that code we've gotten on our phone, multi-factor authentication, or even the color of the car that passed you just a second ago. It's very short. It's stuff that you don't necessarily commit to long-term memory or perhaps even working memory because you only need it for a very brief period of time. Working memory is responsible for temporarily storing and actively processing information. And long-term memory involves permanent consolidation and storage of information that's to last a lifetime. Interestingly enough, folks with brain injuries very rarely have problems with long-term memories because those childhood memories were encoded and stored. But persons with brain injuries may very well have problems with working memory or short-term memory. One of the other memory problems that folks with brain injuries can have is retrograde or anterograde amnesia. Periods of time are lost before and after the accident because information is not being attended to or encoded properly. Retrograde amnesia is memory of events prior to the accident. This can be forgetting a few seconds, it can be forgetting a day, it can be forgetting a year. What we know is that the shorter the period of retrograde amnesia, the less significant the brain injury is. So if you can remember everything up to about 3 minutes ago, better than somebody who can't remember anything from 3 days ago. And anterograde amnesia is the period after a brain injury when someone has lost the ability to encode those new memories. And so they can't necessarily recall the recent past. They can't remember where they are, what day it is, or any of those things. They may not remember who a family member is, and they may not have any awareness of their injury. The last domain of cognitive function I want to talk about today is executive functions. You know, the frontal lobe is highly related to executive function disorders, and the frontal lobes are almost always injured with traumatic injuries because of where and how they sit inside the skull. So our neural highways have been broken, or they've got potholes, and you've got a detour. Executive functions are a set of processes that relate to how we manage ourselves and our world. And so again, we know that injury can cause problems with, abstract thought and paying attention and considering all aspects of a situation to come up with a potential solution. It involves executing those solutions and maintaining some flexibility if the solution didn't work and monitoring yourself in the situation. And that doesn't happen in real time very well for a lot of folks with brain injuries. And this is sort of the executive function wheel. You can look at things like working memory, which holds information in mind to complete a task and update and manipulate information. You could look at something like planning and organization, which is how we plan new tasks, how we anticipate future events, and how we prioritize our day and our tasks to accomplish the things that need to be done. You could look at something like self-initiation. Remember, one of the things that I said earlier was that a lot of folks with brain injuries can look apathetic, but really what's happened is that there's been damage to the part of the brain that gives them that get up and go. So they may not be self-initiated. They may not be able to start new activities, look for new information, think of new things. And you look at something like changing the set, moving freely from one activity to another, and considering more than one aspect to any situation. I wanted to talk for just a minute about a few compensatory strategies that individuals with brain injuries might benefit from. One of the things that I can tell you is that behavior never changes without direct feedback. So you need to let individuals know a behavior is inappropriate. Don't assume that they know it. Sometimes we won't make those same assumptions when someone looks disabled, but we will make those assumptions when somebody looks fine, which is a lot of people with brain injuries. They need straightforward feedback about when and where behaviors are appropriate, and they need redirection if they get off on a tangent or they start talking too much, dominating a conversation. You need to be careful when making inferences about their behavior, and don't presume that non-compliance results from a lack of motivation. Maybe it's damage to the reticular activating system. People who deny their deficits may have problems in their frontal lobe that allows them to see those deficits, to have that level of self-awareness. Often confrontation shuts down thinking and people become rigid. And we'd like for folks not to be discharged for non-compliance. We'd like folks to be followed up with and have someone find out why somebody hasn't shown up. Many individuals after brain injuries will have a unique learning style. Write it down, write it down, write it down. I can't say that enough. Individuals who have attention and memory problems are going to have difficulty. So write it down, get them a memory book, get them a smartwatch, get them a phone, put something in writing for them. Don't just say, put that doctor's appointment in your calendar. Say, put the doctor's appointment, put the appointment with Dr. White in the calendar, because they'll write doctor's appointment, then not know what doctor they need to see. Paraphrase examples, use varied concepts, use concrete examples. When you can, incorporate visual aids, and make sure that somebody paraphrases what you said back to you. You have to get them to repeat it back to you to ensure that they understand it. Allow them to take notes if it helps. Encourage the use of a calendar or some sort of planner. You can meet individually sometimes with folks after sessions to review important points, because remember, sometimes they have trouble attending to the important parts of a conversation. And don't take for granted that something's that been learned in one situation will be generalized to another. That's not always a skill that folks with brain injuries have. I used to work with people in the clinic on doing something like making a quick run to 7-Eleven. Could they manage the change? Could they manage the transaction? Could they keep up with small talk? Did they need some help? What did that help look like? And then eventually we would go to the 7-Eleven and I would begin to see breakdowns. Something that they could do in the clinic did not necessarily carry over to 7-Eleven. And there's a difference in 7-Eleven at perhaps, 2 o'clock in the afternoon as compared to lunch hour. And so somebody might be able to, in a not crowded 7-Eleven, function pretty well, but completely fall apart at lunchtime when all the construction workers are getting hot dogs. So I'm going to stop there. It's time for another break. We're going to break until 11. And when we come back, we're going to talk about some special populations and considerations specific to behavioral health for individuals with brain injuries, and talk about some strategies that we might use. We'll also have a Q&A section at the very end. So you guys, again, get up, stretch, take a break. We'll be back at 11. Thank you.
Welcome back, everyone. Anne will be with us shortly. I just wanted to remind you all, if you have a question, please put it in the Q&A feature. So at the end, we can easily keep track.
Yeah, and I'm going to talk about that substance abuse question in a few minutes, so we'll get to that. Well, what I want to talk about now is sort of the link with brain injury and several other populations that you guys probably know. So let's get started. Well, that related to the strategies that we were talking about in the last section, but I thought there was some really good stuff in there relative to just be willing to try and perhaps think outside the box. So what I want to talk about now, oh gosh, how did that happen? Hang on, I'm at the wrong slide again.
And you might need to stop sharing and reshare.
I'm trying to fix something real quick, Tanetta. So if everybody could just hang on for just a second.
Okay, great. Because we could only see your internet.
Yeah, I need to rearrange a couple of slides real quick. So hang on just a second. Okay, thanks you for your patience. Let's try this again. So this is one of these exercises that I've done when we're in person to sort of prompt people to think about different ways of seeing things. So I don't know how many of you, when you look at this picture, see a young woman in a white hat. She's got dark hair, she's wearing a necklace, and she might have a feather in her hair on the hat. But then I wonder how many of you look at this picture and see an older woman who's also wearing a white hat, but who has a bump on her nose and whose mouth is open and whose chin is a little further down than the young woman's. And I wonder how many of you see both of these. So this is just a sort of a reminder, a little jog, if you will, that people can be sitting in the same space at the same time and looking at the same picture and see two or perhaps three completely different things. And so I want you to think a little bit differently about some of the populations we're going to discuss next. We know that brain injury and domestic violence are tightly linked. Intimate partner violence results in about 2 million injuries every year, but only about 1% of those, less than 10,000, are appropriately identified by the healthcare system. Given what we know about the percentage of assaults that target the head, neck, or face, there could be as many as 23 million women in the United States who've experienced domestic violence and have a brain injury as a result. The rates of brain injury in women who are seen in an emergency department or domestic violence shelter are between 30 and 74%. Most occur directly from a direct blow to the head or from strangulation. I can tell you that BIAV has been working with Virginia Department of Health and some domestic violence shelters to screen individuals there. And 76% of the individuals that we have screened so far have sustained at least one brain injury. Some have had as many as 6. And in this last study of 115 patients screened, only 81% reported a loss of consciousness. So remember, that's mild injury. And of those 115, only 21% sought medical help. We know that brain injury is related to being homeless. You can see here, study after study after study says, got a brain injury, then became homeless. Got a brain injury, then became homeless. And the rate of brain injury in the homeless population is about 24%. Some have it as high as 53%, compared to 2% in the general population. And you think about it, if you have a brain injury, you lose your income, you lose your insurance, you lose your apartment, you can't get along with anybody, you've alienated your friends, you've alienated your family. What's left? The street. We know that brain injury and involvement in the justice system are highly linked. In several studies, we've seen upwards of 60, 70, 80% of individuals in the criminal justice system having had a moderate to severe brain injury, and many more who'd had a mild brain injury. We know that incarcerated individuals are 7 times more likely to have experienced a brain injury than the general population. Years ago, BIAV did a study with VCU and the Department of Juvenile Justice. We screened every child that came to the Bon Air Reception and Diagnostic Center over a period of 18 months. And half of them, more than half actually, screened positive for a brain injury. And you think about what that frontal lobe does and how that frontal lobe is involved in almost every traumatic brain injury. It's what helps us make good decisions. It's what helps us think abstractly about what might happen. It's what helps us understand consequences and what helps us control our impulses. And so when there's damage to the frontal lobe, it's not that big a stretch to see how someone could become involved with the justice system. And the link between brain injury and behavioral health is long studied and strong. We know that compared with the general population, patients with brain injuries are far more likely to have depression, anxiety, and probably PTSD. And the depression is likely to be chronic and persistent. Among veterans, depression was the most prevalent psychiatric comorbidity, followed by anxiety, but far outpacing PTSD. And upwards of 20% of folks who sustain a mild brain injury may experience depression. And that top bullet, let's revisit that. Children who have a brain injury before the age of 5 are 4 times more likely to develop a substance use disorder. Relative to the psychiatric disorders, again, major depressive disorder is the most common Axis 1 diagnosis. PTSD and generalized anxiety disorders, as we talked about. PTSD is not limited to the military population. Organic personality disorder may be one of the things that can be diagnosed in someone with a brain injury. Manic episodes, someone may have bipolar affective disorder, or schizoaffective or schizophrenia. We know that schizophrenia is the most common Axis 2 disorder following brain injury. We know that mental health issues can be a risk factor for brain injury, and brain injury is a risk factor for mental health issues. One of the programs of the Brain Injury Association of Virginia is Camp Bruce McCoy. It's a 2-week recreation and respite program held in Chesapeake for adults who sustained a brain injury. And we have one camper who's been coming for probably 25 years. Jim was in college when the signs of schizophrenia started to make themselves known. And about 6 months after he dropped out of college because of the schizophrenia, the voices in his head told him to jump out of a moving car. And that's how he sustained his brain injury. So what comes first? Is it a brain injury or substance misuse? We know that the two disorders have a really complicated relationship. People with brain injuries have long-standing chronic and legitimate pain. People with brain injuries also have memory problems and can be impulsive in their decision-making. Individuals who have a history of alcohol or other drug use are at greater risk for sustaining brain injury. And sadly, individuals with brain injuries do fall back into or develop patterns of substance use disorders. And persons with brain injuries were 11 times more likely to die of an overdose than the non-brain injured population because of those memory problems, because of their impulsivity. Dr. Hughes Melton spoke at a conference for the Brain Injury Association in Virginia for a couple of years ago. And one of the things that he said has stayed in my head. He said one pattern of drug users when they've changed to a new dealer is to sort of test the strength of the new supplier. But that's not something with people with brain injuries ever think of or can maybe even hold themselves off to do. But we know if you have a brain injury, you're at increased severity of substance misuse. You'll start that substance misuse at an earlier age, and there's a higher likelihood of other disorders. You know, folks with brain injuries very often don't respond to traditional AA sorts of programs. Sometimes they move too quickly, or they require carryover from one session to another, or they require people to be able to, quickly process and respond to information that's coming at them. The other thing about it is if you don't understand the effect that your behavior has on others, and you don't remember what it is that you did, how do you make amends? And so there's been quite a bit of work over the years to sort of tweak some of the substance use substance misuse treatment methodologies and processes to folks with brain injuries. There's been a lot of attention lately to the use of the resiliency model of substance abuse and recovery, as opposed to more the abstinence model, the AAA sort, or the AA sort of model. I can tell you that there have been some recently developed resources that specifically address brain injury and substance use disorder. I'll send some of those links along to Tanetta when I send her the copy of the PowerPoint, and encourage you to look at the Dr. Carolyn Lemsky, Lemsky, is a noted researcher specializing in the intersection of brain injury and substance use, and she's created some great toolkits, and I'll make sure to include that link in the presentation. So after somebody has a brain injury, we know that there are lots of implications. There are lots of behavioral challenges that we face, and some of the functional implications look like these. You know, people become easily frustrated. They can refuse or resist therapy or showers. They may become aggressive. They may elope. They are impatient, and they can destroy property. You've seen some of these things happen when individuals are in a neurobehavioral crisis. We know that behavioral issues can lead to societal challenges. Like I said, this lack of insight and ability to monitor their own behavior or understand the effect that it has on others. When they can't necessarily modulate their behaviors and they have irritating or explosive things that they do, and they don't change those behaviors in response to consequences that might work on somebody else. And these behavioral challenges often lead to treatment challenges. Folks are often considered non-compliant or maybe in denial because the impairments impact and limit their full participation in treatment, because they've had damage to the reticular activating system and they've got no more get up and go, because they've had damage to the limbic system and their memory structures don't work as well as they did, because they have frontal lobe deficits and they cannot understand the impact they have on others. We know people with brain injuries get kicked out of programs all the time. In domestic violence programs, they get kicked out because of their disruptive behaviors and they're late for curfew, or they don't follow through, or they're fighting with their neighbors, or any number of things. And we've seen people with brain injuries get kicked out of brain injury programs for impulse control issues. People can refuse services sometimes due to an inability to understand the benefit of those services. And certainly individuals with brain injuries are vulnerable to substance abuse because of the problems they have in regulating their behavior. When we approach the rehabilitation of individuals with brain injuries, we spend a lot of time on this cognitive rehabilitation model. And you'll see it has sort of 4 layers to it. The first layer is cognitive education. We try to help people become more aware of their strengths and weaknesses. And we focus on developing that awareness as we talk about the impact that it has on various activities that they do. We can initiate specific cognitive training that's designed to be restorative. These were supposed to be things like video games. We thought early on when these things were coming out that they would have far more applicability to cognitive training. We've found some programs do, but some programs don't specifically restore some of the skills that we're looking for, like memory. So what might happen then is that our cognitive rehab strategy would need to focus to something more along the lines of compensating for the deficits and training individuals in strategies to help them mitigate the impact of their deficits. So it focuses on checklists and to-do lists and phones and memory books and all of those sorts of things to help folks overcome memory problems. And then we take all of those things, the education that we've provided, the training that we've provided, the strategies we've provided, And we try to move those into functional training. We'd like to see these people be able to use all of those strategies to function independently in the community. There are a couple of different principles and approaches to these models. Neuroplasticity is a principle. We believe that there are abilities within the brain to reorganize and regenerate structure and function. And we believe that individuals have some adaptability to change their behaviors, either in response to the internal or external environment. When we're approaching things from neuroplasticity, that's when we focus on that restorative stuff. Can we initiate treatment that lays down new pathways, for example? And if we repeat and consistently target that behavior, do we facilitate recovery? One of the things that's popular in brain injury rehabilitation, when there's a physical deficit, is what's known as forced use therapy. If someone's arm doesn't work after a brain injury, we may try the neuroplasticity route. What we would do is have them forced to use the arm that's less functional, because what we know is that when we do that, sometimes we lay down new pathways so that they are able to regain some movement in that arm. If we're working from the adaptability principle, this is when we design the environment to minimize the effect of deficits. And we develop internal and external strategies to make use of the strengths and abilities that someone has.
Cognitive rehabilitation program is one in which people with any type of cognitive deficit, including things like problems with attention, problems with memory, problems with reasoning abilities or problem solving. This program is a program that's designed to help people be able to compensate for those problems in a way that allows them to function in their everyday environments and to meet their everyday functional goals. So typically a cognitive rehabilitation program will be holistic, and that it will want to address every goal that the person has in their everyday environment. It can be done in a group setting or in an individual setting. The advantages of a group setting are that people learn from each other. So people may have a hard time after a brain injury recognizing the problems that they're having with cognition, but they have an easier time recognizing it in someone else. And so the group setting can be used to have people model strategies that have been successful for them and that other people can learn from, and also can be used as a way of having social feedback for people, so that, you know, if another person with injury mentions to someone else that they think they're having a problem, they're more likely to hear it than a therapist tells them the same thing. Another important component besides the group therapy of a cognitive rehabilitation program is individual one-on-one therapy with a neuropsychologist, with a speech therapist, or an occupational therapist who can help you to develop individualized strategies for your everyday goals. And the individual therapy is important because it can address techniques and strategies that fit your needs, and that can't be done in the group setting.
So now I want to talk a little bit about communication challenges. You know, I think that that's one of those things that we hear quite frequently in folks who are working with individuals with brain injuries. But communication is hard for all of us. And so some of these things may be helpful in our everyday lives. But when we look at sort of where some of these things are happening and the problems that they're creating, you know, folks with brain injuries may have trouble finding the right words. Sometimes they'll use inappropriate words. I had a patient one time who was a minister. And after his brain injury, he developed a terrible cussing habit. And he would cuss up a blue streak. And his wife couldn't deal with that. His filthy mouth just upset her so much And I'm not sure that that marriage was able to survive. They were still together when he left the inpatient setting. But that was a communication challenge for her and him. Folks with brain injuries sometimes have problems recognizing and repairing breakdowns in communications. They don't realize that the wheels have gone off the wagon, or that they've irritated somebody, or they said the wrong thing. And they don't necessarily interpret body language and social cues. You know, one of the things that I've said earlier was that the frontal lobe is responsible for abstract thinking. And when the frontal lobe hasn't wired in yet, people tend to think concretely. It's the difference between how a 20-year-old would approach a problem and how a 40-year-old would approach a problem, because there's more gas on the neural highways to the part of the brain that helps you think abstractly. Body language, cues, humor, sarcasm, innuendo, all of those are things that require abstract reasoning that sometimes individuals with brain injuries struggle with. We've talked about their attention challenges, which means they may not be listening very well. We've talked about the difficulty they have understanding another's points of view, and they sometimes don't recognize dangerous situations or even distinguish between minor and serious problems. I worked with a young man one time who was living in his own apartment, and he ended up getting busted because he didn't realize that all of the new friends that he'd made since he moved in were actually dealing drugs out of his apartment instead of their own home. And it took quite a bit of work to get him out of trouble because he had no clue what was going on. He was completely unable to recognize what was happening in that situation. But if you are talking to people with brain injuries in an environment that's too distracting, they're not going to be able to listen. They're not going to be able to encode. They're not going to be able to retrieve. They will not be able to remember. Speaking for or finishing someone's sentences can get them distracted off track, so they never remember the original point, and it's disempowering. So it's really important to wait and be patient for someone who has speaking difficulty after a brain injury. Personalizing or taking inappropriate or aggressive language personally, demonstrating or verbalizing your level of frustration, not providing nonverbal cues, and giving too much or too little verbal information. All of that can be overwhelming to someone with a brain injury and lead to an outcome that's less than you desire. You know, one of the things that I have always talked about in sort of this example is, you know, I used to report some very different levels of assistance that were required when patients transferred from their bed to their wheelchair in the hospital. I would say that someone would be able to transfer between those two services with very little help. But another therapist might say that they needed maximal assistance. The difference was in our approach. The other therapists would come into the room and they would say, "Good morning, Mr. Jones. I'm Joan. I'm from occupational therapy. I'm here to get you up. I'm going to sit you on the edge of the bed. And on the count of 3, we're going to stand up, turn, pivot, and sit down in the wheelchair. And Mr. Jones is back on good morning. You've said too much, too fast, in a distracting environment in too short a time. And you've provided multiple step commands." How did I approach the transfer? I'd put the wheelchair next to the bed and say, "Get over there." I'd help them when they needed it, but I was happy to wait and let them take as long as they needed or ask for help. When you're working with individuals with brain injuries, it's really important to ask them to repeat what you've said. You have to confirm that they have heard and understood your directions. Don't make the assumption, because what will happen if they don't understand, they won't get started, and then they'll be non-compliant. They may need extra time to respond. And don't argue. That inability to shift cognitive sets, if you start arguing with someone with a brain injury, they'll just dig in deeper. You can try rephrasing the problem or perhaps breaking it down into parts. We know that the behavior of the messenger affects the behavior of the recipient. So speak softly, speak slowly, use gestures, maybe other nonverbal communications. One of the things that we know to be helpful is when we are changing topics with someone with a brain injury, we let them know that. Okay, well, that was the last thing that we needed to do for your memory book. We're going to move now into talking about your doctor's appointment later this week and what you need to tell them. So set the environment for them. Let them know that the topic has changed. Let them know that their cognitive set needs to shift. Let them know that they need to work a little bit differently in the next section of your intervention. I'm not going to show this because I think I'm running out of a little time, and I want to make sure I get to everybody's video questions. One of the things I'll do is I'll make sure to include the links to all of these videos in the handouts that I send to Tanetta. You know, when folks with brain injuries get into crisis, it's not all that different from when folks with behavioral health get into crisis, or when folks with autism may experience the crisis. And our interventions are the same. We need to actively listen. We need to ask them what their perception of the crisis is and see if we can't focus on, you know, the immediate past and the immediate future to help de-escalate the situation. You can reflect their feelings, you can reflect their content, you can paraphrase and summarize. It just reduces the heat, and particularly if you drop the volume, if you drop the pitch, if you talk more slowly, all of those things will de-escalate a situation. It may not work completely, but it may help cool things off. When we talk about individuals with brain injuries and pharmacological interventions, there are many, and there are some that we share with other populations and some that are unique to brain injury. We know that individuals with brain injuries are often placed on stimulants like Ritalin or Provigil to enhance their attention and their arousal, the functioning of that reticular activating system. We know that folks with brain injuries are often placed on antidepressants. These activate neurotransmitters and improve mood. I mentioned earlier that we conduct a camp program. It's very interesting to see what the flavor of the month is with antidepressants, because we'll have people show up and their antidepressants will have changed after years of being on the same one, and usually it's a new drug that somebody is trying. But things like Zoloft and Celexa and Effexor are some of the antidepressants. In terms of anti-anxieties, we know that Ativan can be used and Xanax. Those drugs have half-lives that's somewhat concerning, but they're still effective for individuals with brain injuries. Mood stabilizers may also be used. And antipsychotics are often used with individuals with brain injuries, but may not work very well. So the use of antipsychotics needs to be carefully monitored. And one of the things that I would say, and I firmly believe, is that if you're working with someone and in the course of your work, you determine that they do have a brain injury, you may want to have someone with some specific expertise in brain injury take a look at that med list, because psychiatrists prescribe meds all the time that physicians who work with folks with brain injuries wouldn't prescribe. And so it's not a bad idea to have a pharmacological second opinion for some of your clients with brain injuries. I want to talk for just a minute about neuropsychological assessments. Neuropsychological evaluations give us this really rich picture of someone's strengths and their abilities and the weaknesses in various areas of functioning. You know, what it does is determines the extent of the cognitive deficits and whether or not there might be a presence of other psychiatric or neurologically based disorders. Neuropsychologists are experts in brain behavior relationships, so they're able to help us understand how specific deficits can contribute to a problem in daily life. And if there's damage in a particular portion of the brain, we might want to keep our eye out for this problem in the future. So we can determine the nature and degree of change when we reassess individuals. When I got a neuropsychological assessment on a brain injury patient, I would go immediately to the recommendation section because there were some great ideas that were going to help my therapy. Because neuropsychologists will assist in treatment planning and make recommendations for modifications to the environment, to strategies in the community, to any number of things. Neuropsychs will look at all of these skills during their testing process, which can sometimes take days for someone with a brain injury because it's exhausting. And psychologists don't necessarily use some of the same tests that neuropsychologists use. There's just a little bit different emphasis in some of the training. But the domains of a neuropsych test will include premorbid level of function, tests of attention and concentration, perception and processing speed, how well someone manages their executive function, what their intelligence and intellectual achievement is, particularly as regards premorbid level of functions, and if there are any additional factors that might improve or affect cognitive functioning, like pain, like depression, like anxiety, like medications. When someone is referred for a neuropsychological assessment, the first thing that will happen is an extensive record review. When we were working in the juvenile justice process, we had very limited ability to go back and look at some of these kids' records because for some of them, it was the first time they'd ever seen a doctor or a dentist or had had a really good educational assessment. So neuropsychs will find whatever record is available and try to get a picture of what this person functioned like prior to the interview, prior to the injury. And then they'll conduct a clinical interview. They'll take them through a structured interview process and ask them the questions that lead them to determine what sort of battery they want to use. There are fixed batteries, which are standard and normed tests covering every functional domain that a neuropsychologist might look at. But they may also decide to use a flexible battery based on what they found in their record review and in their interview. They may want to do some patient-tailored testing and just really focus perhaps on executive function or speed of information processing. They base and select their assessment instruments on referral questions and impressions from the initial interview. So they'll move them through this process and then they'll provide a report and some feedback that will have all of their behavioral observations, the list of tests and the validity of those tests in assessing the challenging behavior, description and interpretation of results, and a thorough summary that includes strengths and weaknesses and impressions and functional implications and all of those sorts of things. Neuropsychs are worth their weight in gold when it comes to folks with brain injuries. Now, we talked earlier in this session about some special populations, and I want to talk for just a minute about brain injury screening. You've got people on your caseload that have a brain injury, I can guarantee you. But here's the thing, if you're not being treated for the right thing, you may not get better. If you're giving cancer drugs to a diabetes patient, that's not going to help the cancer. And if you're treating somebody with a brain injury without understanding the context of the brain injury or the problems of the brain injuries, their memory problems, their attention problems, their executive function problems are going to continue to rear their head because you haven't addressed the root of the problem. Not every brain injury is the same. You bring the brain that you have to the accident. And because every brain is unique, every injury is unique. There are more than 600 neurological diseases and disorders. So sending somebody to a neurologist might not be as helpful as you think, particularly if they're not familiar or knowledgeable about brain injury. So it's really important that we begin screening practically everybody that we come in contact with. If you've got somebody on your caseload that's got a criminal justice history, red flag. If you've got somebody on your caseload that has had bouts of homelessness, red flag. If you have somebody with a behavioral health diagnosis, red flag. I'm going to show you a couple of easy screening tools that you might be able to use. The HELPS is a 5-question screening instrument that asks questions about the injury history, medical evaluation, assesses the loss of consciousness, and whether or not there have been any problems since the injury. The Ohio State University TBI identification method is similar to the HELPS, but it asks for a good bit more information, and it includes an interpretation scale. So let me show you what those look like. The OSU interview form takes about 3 to 5 minutes. You see in question 1, they ask you about injuries to your head or neck that you may have had at any time during your life. Have you ever been hospitalized? Did you ever, crash into something? Have you ever injured your head from a fall or being hit by something? Have you ever been hit by someone? Or have you ever been nearby when a blast occurred? In step 2, they'll ask a question about a loss of consciousness. And in step 3, they ask if they've experienced multiple repeated impacts. And a few follow-up questions. And they document all of that down here in this section. The answers to step 1, step 2, and step 3. Additional consideration needs to be given about the potential effects of exposure when there's been more than one injury, when there's been any injury with a loss of consciousness before the age of 15, when there have been 2 brain injuries within close proximity to each other, less than a year, or there's been a mild brain injury in recent weeks, or more severe brain injury in recent months. The HELPS screening tool is a little easier to administer. It asks 5 questions. H, have you ever hit your head or been hit on the head? E, were you ever seen in the emergency room? L, did you ever lose consciousness? P, are you having any of these problems since you hit your head? And S, are there any significant sicknesses that may have impacted? And if all you can do is ask the first question, it's going to change how you approach the person with whom you're working. One of the downsides to both the Ohio State screening instrument and this screening instrument is neither one of them really focuses on brain injury as a result of strangulation. And so when we use these screening tools with individuals who have been a victim of intimate partner violence, we will throw in a question about strangulation. In Virginia, the Department of Aging and Rehabilitative Services is the lead agency for issues related to brain injury. And there are 9 state-funded programs that provide a variety of services that include resource coordination, case management, clubhouse and day programs. You'll see those 9 organizations listed there, and they cover the state of Virginia. In Southampton Roads, Eggleston Services operates case management services and a clubhouse for persons with brain injuries. And they can be a terrific resource for you when you're struggling to serve someone with a brain injury. If you'd like to contact DARS, Chris Miller is the director of the Brain Injury Services Coordination Unit, and I've included her email and phone number. I just want to leave you with a couple of helpful hints. You know, if there's a plan that needs to be enacted, please spell each step out and write it down for somebody with a brain injury. You'll get a lot further than being resentful that you have to do it. You need to speak slowly and allow for that increased processing time because of the damage to the neural highways of the brain. You need to limit the amount of information that you give at one time. We're all overwhelmed and stressed right now. And so this is a good tactic for approaching a lot of folks, but it's really a good tactic for approaching folks with brain injuries. You give them multi-step commands, they're not going to remember. You give them too much information, they're not going to remember all of it. They can't take it in, they can't encode it, they can't store it, they can't retrieve it. The very nature of brain injury lends itself to disordered thinking. So if someone can't get organized and can't plan, give them strategies to do that, because the brain injury is going to make that difficult. And one of the best pieces of advice that I ever got is assume positive intent. At any given time, you have to believe the person's doing the best that they can, because that makes it easier on you and easier on them. Here's some information about the Brain Injury Association of Virginia. I'm so, again, delighted to be able to talk to you all today, but we are here for you anytime you run into some challenges. Our information and referral staff have more than 100 years of brain injury experience, and Christine Bagini, who is our resource coordinator, can be an invaluable source of resource information for you if you're struggling with a particular case. So that's the end of the presentation, and I'm happy to start tackling some of the questions now. So, does the length of time between two brain injuries impact whether or not one will most likely have a third brain injury? I don't know that the length of time is quite as important as a history of one injury, because what happens after you have an injury, if it's significant enough, you might have some vision problems, you might have some impulse problems, you might have some memory problems, and all of, maybe even some balance problems, and all of those things just sort of leave you at risk for another brain injury. Second question, is it possible for a child at childbirth to be born a blue baby, experiencing oxygen deprivation at birth, and anxiety and depression issues not manifest and reveal itself until the 4th grade? And that's absolutely possible. You know, our brains develop every day that we suck in and expel oxygen. And so as our brains develop, we experience new challenges because we're designed to meet those challenges. And so 4-year-olds are beginning to become more aware of the external environment. And so as that brain adapts to this new level of expectation, depression can sit in, even though, you know, from 0 to 4, they didn't necessarily seem to exhibit some of that depression and anxiety. So it's possible, yes. What foods are of greater value in helping repair the brain, and what foods should be avoided? Well, I can tell you that alcohol and sugar and refined carbs are things that you absolutely do not want to be eating if you want your brain to work better. Sugary drinks, those that contain aspartame, food high in trans fats, are big no-nos. The things that you want to eat to improve brain health are things like fatty fish and eggs and leafy greens, nuts. Pumpkin seeds are awesome. They have so many amino acids in them that are really good. And one of the really good foods for you to eat is dark chocolate. So y'all have at it. What do we know about the intersection between substance use and TBI? Do you have any recommendations on providing therapy to individuals who have brain injuries? with co-occurring substance use. So we talked about that a little bit, and I am going to be sending out the toolkit, and that's going to have some specific information. I know that DARS is planning to hold a 1 or 2 day educational event with Dr. Limsky to specifically train individuals who are experts in substance use to work with individuals with brain injuries. And BIAV is going to try to begin creating some materials that will be helpful for you through a grant that we're hoping to get from the Virginia Department of Health. VCU recently did a study that looked at the use of opioids in the brain injury population. And I'll send that information out too with a link to that article when it comes. It'll be really eye-opening for you. People with brain injuries are practically predestined to develop substance use problems because of the meds that they're given when the injury is acute and the pain that they're facing. Is that figure from the CDC about the rate of intimate partner violence resulting in TBIs that are diagnosed still accurate? It looks like it's from 2003. I'm not entirely sure that the 23 million is actually an accurate number, but the scope of it does reflect a very, very high number. When you consider that the number of individuals who experience domestic violence and then overlay what we know about the likelihood of brain injury, it's a really high number. But thank you for asking that question. I'm going to go back and see if I can find something that's a little bit more current. I tried to do that with all the rest of them, but I may have missed that one. Could you all define marginally housed as a subpopulation of individuals suffering from brain injury? We know that folks with brain injuries are much more prevalent and represented in homeless services, but I'm really unclear on what marginally housed refers to. Are those literally unhoused, or those who are simply unstably housed? And I think for marginally housed, it's those who are unstable. If they're couch surfing, if they're finding a hotel room for a couple of days and staying there, if they have some family that they can go visit, but they have no safe, consistent place to live. What diagnosis should be primary when someone has a brain injury and they have IDD, substance abuse, mental health, and/or a dementia? Well, isn't that a really interesting question that nobody has a good answer for? My perspective is that with the exception of IDD, most of those folks are going to have some level of brain injury that preceded, in a lot of instances, the substance abuse or the dementia or the mental health issue. And so you almost have to think about that brain injury, not necessarily as a standalone, but as a standalone consideration. Did a brain injury happen before any of these other things? And if they did, let's see if we can get that under control. Get someone who specializes in brain injury to see this person and see if we can't figure out sort of a pecking order of things to approach. There's a neuropsychiatrist in Richmond. His name is Greg Oceanic. And so Greg he's trained as a psychiatrist and he specializes in brain injured persons. And so I think that, Greg and other physiatrists who specialize in brain injury might be really helpful in trying to determine this. I don't know that a neurologist is going to be that helpful. Particularly if they don't specialize in brain injury, if they specialize in something like Parkinson's or ALS. I know someone who has been prescribed medical marijuana to decrease their anxiety. Have they heard of this? I have. And I can tell you that the brain injury community is really wishy-washy when it comes to a position on the use of medical marijuana among individuals with brain injuries. We know that medical marijuana can also help individuals manage seizure thresholds, but Marijuana can also have cognitively blunting effects and problems with memory. So there really hasn't been much of a statement from the brain injury community. And I've even asked BIAA about this. But there's been a growing amount of research into this intersection between substance use and brain injury, and I have a feeling that we'll be having some recommendations come out in the not too distant future. Can traumatic brain injuries within the mother affect the baby in utero? It's entirely possible if the mother is not eating well, if the mother is not sleeping well, if the mother is engaging in dangerous behavior. All of those things could affect a baby in utero, but not necessarily mean that that baby is going to develop significant problems later on. There may be a link between that activity and what happens to the baby later on in life, but there's not a direct link that we know of that leads to cognitive issues in these kids later on in terms of TBI affecting the babies. And can a child with a mild concussion exhibit seizure-like symptoms during sleep months later? You know, that's a really great question, and I don't know the answer to that. And I think I'm going to write that one down and ask a few people that I know. I think, you know, for me, that seems sort of stretchy. And I've seen, you know, dogs sort of develop some of that, you know, seizure-like behavior in cats, and other people do weird movements when they sleep, but I don't know. So let me ask that question, and if I can get back to you with an answer, I will. I love it when I get asked good questions. And then there's another question. We know childhood trauma can affect multiple generations. Makes sense that a TBI would do so as well. Taya, you are exactly, or Taya, you are exactly right. You know, I find it fascinating that the number of people that work with individuals with brain injuries are less informed about trauma-informed care than you might think. I mentioned earlier, we were doing a study with the Virginia Department of Health to screen individuals who've been experiencing domestic violence for a brain injury. One of the things we're doing as part of this project is we are referring these individuals that screen positive to brain injury case managers. We didn't want to tell them, oh yeah, you got a brain injury, good luck with that. We wanted to be able to refer them to services. But in working with the brain injury programs to raise their understanding and comfort level of this population, and working with individuals who've experienced assault and domestic violence, we asked them how many of them had had specific training on trauma-informed care, and very few of them had at the time. I can tell you they've had it now, but I think that it leaves an imprint for a very long time on a family. Brain injury very rarely makes a family more functional. And that environment can have, you know, significant impacts on the folks that we work with. So that's all I've got. Tanetta, I don't know if you've got anything else. You guys have been great. You know, sitting on a 3-hour Zoom is tricky and tough. And I'm just really, really grateful for the opportunity to have talked to you all, to tell you a little bit about brain injury, and we'd love the opportunity to work with you more closely to help you serve some people we care an awful lot about. Thank you very much.
Thank you. I don't have anything else. I just wanted to say, please give me 1 to 2 weeks just to compile all the information, get the email out and the CEs out, and to get the recorded video posted to our website. If it's been more than 2 weeks and you have questions or you didn't receive an email, you can always reach out to me directly, and I will put my email in the chat. Otherwise, we appreciate you. Thank you all to our guests that helped make this training more accessible. And we wish everyone to have a good day.